Nandini, you can start.
Okay. A very good evening to everyone. I welcome you to the Medicine Forum. I am Nandini Srinivasan, a third-year medical student, and I'm here to welcome you to the Medicine Forum. It gives me immense pleasure to introduce Medicine, a platform that has rapidly grown to become a trusted educational partner for medical students across India. Our mission is simple: to provide accessible, high-quality education services, resources that empower students to excel in their academic and professional journeys. With a vibrant community of over 23,000 YouTube subscribers, Medusane has made a significant impact in areas like clinical case presentations, theory lectures, MCQ discussions, career guidance, and skill development. We are constantly evolving to meet the needs of our students, whether they are preparing for competitive exams or seeking to build strong foundations in medical practice. One of the things that make Medusane stand out is a commitment to mentorship. While there are numerous platforms offering medical education, Medusane uniquely emphasizes personalized mentorship. We aim to provide students with daily guidance, one-on-one support, and practical insights that go beyond textbooks, helping them build confidence and clarity on their career. As we approach the World Diabetes Day, we are reminded of the importance of awareness, education, and collective effort in combating one of the world's most pressing challenges, that is the diabetes. This year, we are excited to present a special lecture series dedicated to deepening our understanding of diabetes from its physiological and biochemical foundations to its management and complications. World Diabetes Day is more than a date on the calendar. It's a global call to action. Diabetes affects millions of lives, impacting not only the patients but families and communities. Through this series, our goal is to bring together experts in the field to share valuable insights that will empower healthcare professionals, students, and the broader community to tackle diabetes more effectively in the daily practice. Each session is designed to address crucial topics from the basics of insulin function to advanced management strategies along with the latest guidelines. This initiative emphasizes the role of continuous learning and collaboration in addressing the diabetes and aims to equip you with practical knowledge and skills that are essential for improving the patient care. We believe that raising awareness and fostering understanding of diabetes is vital in reducing its burden on society. We are grateful to our distinguished speakers and enthusiastic participants for being a part of this mission. Together, let's make this World Diabetes Day a step forward in our journey toward a healthier, diabetes-aware world. Today, we are extremely proud and happy for successfully completing 7 sessions in the diverse field of diabetes. And for the 8th session, we have our beloved speaker, Dr. Ram Kumar Sir, Senior Resident at Kozhikode Medical College. I would like to call upon Dr. Rangwanda Sir, the founder of Medusane, to welcome our speaker. Over to you, sir.
Thank you, Nandini. It's really a pleasure to have this wonderful series of discussions which we are having for the past 8 days. And I welcome Dr. Ramkumar Sir, Senior Resident, Department of Neurology from Kozhikode Medical College, for accepting our invite and being present today for explaining and sharing his knowledge with us on the topic diabetes and neurology. As you all know that there is a lot, we have a lots of cases, and as a medical student as well as after completing a medicine, as private medical colleges are booming across, I feel that there is a need for discussion of the diabetes per se as a topic, because that is very important from a general practitioner point of view, and most of us are sitting as a casualty medical officer after completing MBBS. So this series of lecture emphasizes to share the knowledge from experts of the field and improve our focus, our guide, our things that are to be read. And I think so this series is doing its justice for that. And I welcome our distinguished speaker for the day. And I also thank all the organizing team behind this. Thank you once again. And sir, thank you once again for joining with us. And now the session is yours, sir. You can introduce the speaker and then sir will start.
Okay, sir. So we have Dr. Ram Kumar Sir, Senior Resident at Department of Neurology at Kozhikode Medical College. He did his MBBS at Indira Gandhi Government Medical College and his post-graduation at Polycode Government Medical College and the doctorate in medicine at the same institute. He has got an All India rank of 11 in the medical group in the NEET super specialty, which is astounding. And he had also previously taken senior CNS case discussion for final years. He's a fantastic academician and a clinician. So I welcome you, sir, to enlighten us on the topic of navigating the impact of nervous system. Thank you, sir. Over to you.
So your voice is not audible, sir. Please unmute yourself, sir. Please unmute, sir.
Can you hear me now?
Yes, sir.
Okay. Thank you, Medusane, for giving me this opportunity, especially Raghu, for giving this opportunity to present a forum like this. And for the past 1 week, we are this beautiful session on diabetes. And today, I'm going to talk about diabetes and neurology. I'm going to, it's going to be a 20 to 25 minutes talk. And why I chose this was like diabetes is not only diabetic neuropathy. There are many conditions where in specific to diabetes and associated with diabetes, which there are which we miss actually. So, but those are all clinically we can easily pick up in clinically we can easily pick up than going in for diagnostic studies and other things. So I chose this, and this talk will be mainly, and I will not go into details of any particular entity. I will just briefly cover upon everything so that it should be a whole topic coverage. And I have given you the links in the slide itself. You can, if interested, you can go and just read about those articles, which are very good. And I will be briefly telling everything, and I'm not going to touch upon the treatment aspect in detail. So with this, I will start the session. So we all know we can divide the nervous system into central nervous system and the peripheral nervous system. And the central nervous system has brain and spinal cord, and the peripheral nervous system has a somatic, that is peripheral, the nerves and the autonomic nervous system. Why I'm telling this is, my talk will be based on what are all the diabetes, how diabetes can impact your brain and spinal cord, autonomic nervous system, and the somatic nervous system. First, I will go into the brain and spinal cord. So in brain and spinal cord, the diabetic patients can have present with transient ischemic attack, cerebrovascular disease, MC is minor cognitive impairment, dementia. They can present with seizures, diabetic steatopathy, spinal transient ischemic attack, and infarction. So first, going into the stroke. We all know the TIA, that is transient ischemic attack, is it's like a warning sign for a stroke, which is one of the risk factor. If you calculate a risk factor, in the diabetes is one of the things. There is something called ABCD2 score. In that, diabetes is one of the things. So it's very important and diabetes and patients can present with TIA. Whoever a patient, whenever a TIA patient comes to you, you have to look for the diabetic, the sugars and the BP, and also the other parameters. So it is very important. Second, in the types of stroke in diabetes, it is the ischemic stroke that are more common than the hemorrhagic stroke. And this diabetes is the strongest determinant of silent brain infarctions, like silent cardiovascular disease. It's a silent brain infarctions are so common. When we take up the MRI of the diabetic patients, we can see lot of lacunar and lacunes are there, which are a strong determinant of silent brain infarctions. So it is very important. And third is a lacunar stroke. Lacunar stroke is a stroke that affects the penetrating artery, single penetrating artery of less than 15 millimeter in size when we take the MRI. So it is a typical type of stroke in diabetics. That is, the patient can present either with the lacunar syndromes are the 5. One is patient can present with a pure motor syndrome. Second is a pure sensory syndrome. Third is sensory motor syndrome. Fourth is your the clumsy hand dysarthria syndrome, like patient can present with clumsy hand and patient can have a dysarthria. And last is the ataxic hemiparesis. That is both the components, ataxia and hemiparesis, in the same patient in the same contralateral side of the body to the infarct. So these are all the type of stroke, and the main pathophysiology behind that is because large artery atherosclerosis, the diabetic can cause stroke by three major pathology. One is large artery atherosclerosis, where it can we went through the pathophysiology in the last lecture, where it was beautifully told about how dyslipidemia, glucose, and the various pathways that are involved and which will cause the vascular reformation and vascular atherosclerotic formation. Second is the cerebral small vessel disease, where because associated with age and hypertension, there is a lipohyalinosis of your arteries that is involved, which will cause your small lacunar stroke. Third is your cardiac embolism, whether it can be an artery to artery embolism or a cardiac embolism. So these are all the three pathophysiology of stroke caused by a diabetes. Third, now we can see here. This picture shows the cortical territorial infarcts. That is, this is the when we draw a line like this, that we can divide it into this area is your anterior cerebral artery circulation. This is your up to when this is the temporal horn of the lateral ventricle. If we draw a line here, this is the watershed area. So this is your posterior cerebral artery circulation, middle cerebral artery, and the anterior cerebral artery. So this large vessel atherosclerosis can cause cortical territorial infarcts. So and this you can clearly see, this is the MCA territory infarct, this is the ACA territory infarct, and this is the PCA territory, that is posterior cerebral artery infarct, where patient can present with your homonymous hemianopia, and if bilaterally it is involved, the patient can cause cortical blindness and all. So the second is the lacunar infarct. Lacunar infarct, it is the single penetrating artery infarct. If involved, it causes lacunar infarct, and it is in the specific areas, that is basal ganglia, thalamus, and your pontine pons. So next, coming with what the effect of hyperglycemia in acute stroke and on thrombolysis. Here, 2/3 of all the ischemic patients are associated with hyperglycemia. So this hyperglycemia can cause increase in the final infarct size, reduces the penumbral tissue salvage. That is, penumbra is the salvageable tissue. Not the salvageable tissue by if we can do the thrombolysis, or if we can do mechanical thrombectomy to remove the clot, we can save it. So, but it reduces the penumbral tissue and increases the lactate production in brain, which causes the effect. And it in fact impairs the effect of thrombolysis. And last, it increases the risk of hemorrhagic transformation. So when we see the criteria in the thrombolysis criteria, one of the criteria is the hypoglycemia or hyperglycemia. We should not lyse the patient. We have to reduce the sugar, and then only we can lyse the patient. This is the important of this. And other anti-diabetic drugs patients are taking. Patients, when taking SGLT2 inhibitors, GLP-1 analogs, and metformin, already have because diabetic drugs usually they prescribe based on the cardiovascular outcomes. Second, these agents can also reduces the risk of stroke. So, so this is the effect of anti-diabetic drugs on stroke. Second, coming to minimal cognitive impairment and dementia. So diabetes is associated with 1.5 to 2-fold increase in the relative risk of cognitive decline and dementia in the later life. Diabetic patients have 59% increased risk of developing dementia compared to non-diabetics, and it may begin changes may begin early. So we have to pick up. And elderly diabetic patients with the history of severe hypoglycemia, on and of hypoglycemia, face a higher dementia risk. And diabetes is usually more associated with the vascular dementia than Alzheimer's disease. And this minimal cognitive impairment can go into the major cognitive impairment, that is dementia. Diabetes is making a major role. Third is your seizures. Both hypoglycemia and hyperglycemia can produce seizures, but hyperglycemic seizures are more common, and that too elderly of more than 60 years of age. Third is it's the focal seizures, that is focal seizures, that is involving either a single hand, the face twitching, or your one side of the body, usually it will be involved than the generalized tonic-clonic seizures. Other things are, there can be visual hallucinations, hemianopia, cortical blindness, or occipital lobe seizures, where patient can just see an object, just follow an object, and their head may turn towards one side. That is a subtle finding of occipital lobe seizure, where it will not present with the focal or generalized tonic-clonic seizure. The patient will follow as if he is following some object in the ground or in front of him. He will he will follow, and after some time he is come to normal. If you don't pick up that, you will miss it. And after that, the hyperglycemic insult will happen on the MRI, and will have a deficits. And these seizures are significantly associated with poor glycemic control. Second is the hypoglycemia. Hypoglycemia, usually we say less than 70 milligram deciliter of deciliter. And early warnings will be shaking, trembling, sweating, hunger, palpitations, like that. And if it goes into the neuroglycopenia, there can be mild, that is impaired cognitive dysfunction, mild diplopia, dysarthria can occur. More advanced, they can go for confusion, change of behavior, and sometimes in the more advanced stages, they will go for the seizures, coma, and if it is prolonged and profound, the brain death can happen. But this neuroglycopenia is more common in type 1 than type 2 diabetes. And insulin, sulfonylurea, and meglitinides. Usually, these are all associated with the hypoglycemia, neuroglycopenia. Sulfonylurea, especially long-acting. Like, and this hypoglycemia is 1.5 to 6 times increased risk of cardiovascular event and mortality. So, and it has an increased risk of cognitive decline and dementia. And also it has a risk of falls and fractures in the elderly. So, it is very important to prevent the recurrent hypoglycemia in an individual with diabetes mellitus. Now comes this diabetic steatopathy. Sometimes patient will present with it's a disease phenomenon characterized by either choreobalistic, that is chorea and balism. I will explain you. Movement or suggestive signature changes in the striatum on imaging, or the presence of both. That is called either the patient has a clinical thing, or MRI changes should be there, or CT changes should be there. It is a complication of a long-standing, poorly controlled, non-ketotic hyperglycemia with acute hyperglycemic surge. It can also be a first presentation of previously undiagnosed diabetes. So, if you see this phenomenon, you have to first order sugars. So, you can see this video. This is an elderly lady. Can you able to see the video?
Yes, sir.
Can you see the video?
Yes, sir. Yes, sir.
Okay. I will just once more. I will just put. You can see this elderly lady coming to our OPD with. You can just see she is not sitting correctly. She is just dancing, and see her right upper limb and lower limb. Can you see the proximal movements? That is a flinging large amplitude movement, and see her the distal. She is just trying to hold that, and that is what is called parakinesia. That is, she is making, this is purposeful. She has some movements, and she is making it like she is doing it for some purpose. This is what is called balism and hemibalism, hemichorea. So I will just play once more. Concentrate here for the ballistic movements. There you can see. And then just concentrate here and the lower limb, this side. See, this is the chorea. So, and it's a unilateral chorea. Always look for diabetes. So, it may be a first presentation of the diabetes. So, when you see when you take a CT head, this is a CT head showing hyperdensity of the caudate nucleus on the striatum. You can see the hyperdensity. This is a bilateral hyperdensity. This is T1 weighted image. You can't see it in the T2 weighted image. It's a T1 weighted image where you can see a hyperintensity. And here also the hyperintensity. So never forget, when a patient presents with right-sided hemibalism and hemichorea, think of diabetes. There are other causes and structural lesions has to be ruled out. First, check for the sugars. Second, and since we consider optic nerve as a continuation of your brain, I want to put it this entity here. It's a non-arthritic anterior ischemic optic neuropathy. That is, the optic nerve is going in for ischemia, and it is anterior. And non-arthritic, just because the arthritic is the classical giant cell arthritis will involve arthritic AAON. This is non-arthritic AAON. 50% will have a hypertension and 25% will have diabetes. And it's a painless loss of vision in an elderly individual with relative afferent pupillary defect, optic disc edema, and peripheral sectoral hemianopic field defect. If a patient comes early morning, that is, vision loss will be noted on waking up in the morning, and loss of vision may progress over minutes to days. So when an elderly individual presenting in with cardiovascular risk factors, presenting with a painless loss of vision, and that too noticed on waking up in the morning, think of this. And highly unusual for and this, there will not be any profound vision loss. There will be mild vision loss only, so we may able to miss it actually. And whenever you see this, check for the contralateral eye, not the same eye. Either it will show an evidence of optic disc pallor from the previous episode of non-arthritic AON, or in that there will be small or absent physiological cup, that is disc at risk. Because next time he will have a this eye, he may have a non-arthritic AON. Initially, the optic disc is usually associated with characteristic prominent, dilated, frequent telangiectatic vessels over the disc, and much more numerous pericapillary retinal hemorrhages than in non-diabetics. Because if you see this finding, it is more common in diabetics than the non-diabetics. So here you can see this is the normal one. This is of a same patient. This is a normal disc. And now you can see the disc margins are blurred, and you can see a papilledema. And once after recovery, this you can see a pallor here, where the temporal part is more, that is sectoral pallor is more common. So with this picture, patient may come to you. So you have to look for the contralateral eye. And here there is a splinter hemorrhage. Splinter hemorrhage is there, where the patient is also showing papilledema, and then there is a hyperemia, and there is a splinter hemorrhage. Now comes these are all the central nervous system. Now coming to peripheral nervous system. So we all know it's a neuropathy. Neuropathy in diabetics can be either a generalized symmetrical polyneuropathy, which is a distal sensory or sensory motor polyneuropathy. We call it as DSPN, which is more common. Most common is this one. Then either large fiber neuropathy, small fiber neuropathy, or autonomic neuropathy. Then comes your focal or asymmetrical neuropathies, where you will have a cranial neuropathy, either a single cranial nerve or multiple cranial nerve can be involved. Truncal neuropathy, where thoracic radiculopathy can be there. Limb mononeuropathy, either a single nerve or a multiple nerve can be involved. And lumbosacral radiculoplexopathy. And in combination, you can get a polyradiculoneuropathy or diabetic neuropathic cachexia. We will just go into, I'm not going to detail of everything. I will just show you 1 or 2 slides of everything. What you have to pick it up clinically. First is the distal symmetrical polyneuropathy. This is the most common, and 3/4 of all the diabetic patients have this. And sensory deficits predominates. Autonomic symptoms correlate with the severity of neuropathy. Only minor motor affection, which causes mild wasting and weakness of distal lower limb, and that too dorsiflexion and EHL are more affected. That is extensor hallucis longus. So whenever you see a patient with diabetic patient with predominant motor involvement, think away from simple diabetic peripheral neuropathy. It is something else. Usually, distal symmetrical polyneuropathy of diabetes is sensory predominant. Mild motor will be there. No much great motor involvement is there. And it's a length dependent neuropathy, and stocking and glove pattern. That is, it's like wearing a socks and gloves. Initially, it will start in the lower limb, and then only it will come to upper limb. Because if you see a upper limb involvement first, you have to think away from normal diabetic neuropathy. And distal reflexes will be absent. If a patient presenting with the stocking pattern, that is only your and the reflexes are present, think away from distal symmetrical polyneuropathy like a myelopathy, there spinal cord infarction, spinal cord involvement. And this is the one. So first, what happens is the neuropathy, like the symptoms will start here and it will go up to knee. After that, because it's a dying back phenomenon, the next one is the next longest nerve will be in your upper limb. So it will start here and then it will go up to your wrist. After that, it will again start and up to mid thigh it will come. and again it will start and will go to mid-arm, forearm, and then your anterior abdomen, anterior trunk, and here it will be involved, and perioral areas will be involved. It's the classical pattern. So it's a dying back axonal neuropathy. It's an axon degeneration starts at the distalmost part of the longest nerve, because in any metabolic disorder, toxins, drugs involvement, usually the metabolism is affected. Cell body is the your powerhouse of your metabolism. If that is affected, the distalmost axon will be deprived of energy. So what happens is the distalmost axon in your body is your lower limb. So lower limb will start getting affected till your knee. After that, the longest nerves will be your the upper limb, and then it will come up to thigh, and then it will come up to forearm. It is in that longest part will get involved. So if you see this pattern, think of not only diabetes, any metabolic involvement like a CKD, CLD patients, and any drugs, any toxin, that is like ethanol, like a toxin is like your alcohol. Everything will present with the same finding. If you find the same finding, the concept is cell body is involved and the metabolism is affected. So it will present with the classical length dependent neuropathy, or since it starts in the lower limb, it's the stocking, and then it will involve the upper limb. So it's a glove, stocking and glove pattern. So since MBBS and post MBBS are there, I just want to briefly tell about what is a large fiber neuropathy and what is a small fiber neuropathy. Large fiber neuropathies usually have a alpha afferents, which carries the proprioception, and A beta cutaneous touch and the vibration. The symptoms will be numbness and paresthesia, sensory ataxia, slippage of chappals unknowingly from your footwear, and feeling of walking on a cotton wool sensation, and sticky feeling on soles. These are all the symptoms of your large fiber neuropathy. What will you see? You can see a muscle weakness and atrophy distally, loss of deep tendon reflexes, positive rhombox sign, and vibration and joint position loss. And a small fiber neuropathy is unmyelinated C fibers, and the thinly myelinated A delta fibers usually carry the temperature, pain, and touch, and also the autonomic nerves like pseudomotor, thermoregulatory, cardiovascular, gastrointestinal, urogenital, and other functions are carried out by your autonomic fibers. Those are also unmyelinated C and the thinly myelinated A delta fibers. So it is a symmetrical length dependent polyneuropathy. So the symptoms are either numbness and paresthesia, but burning pain, warmness of cold, itch. Never forget, itch is a small fiber symptom. Patients presenting with the itch, think in appropriate situation, think of small fiber neuropathy. Mainly post-herpetic neuralgia patient will present with itch. After in the dermatome, they will have itch. So itch is a small fiber symptom. Nocturnal deep aching pain and dysesthesia and allodynia, and loss of pain and temperature, and look for the autonomic features. Never forget, that is dryness and discoloration of skin, dystrophic changes of feet. Those are all the your autonomic symptoms. And coming to autonomic neuropathy, as such, it can be either a autonomic neuropathy can be your cardiovascular autonomic neuropathy, where reduced heart rate variability, resting tachycardia can be there. Orthostatic hypotension, that is when the patient is in a supine position, and if he gets up from the supine to standing or sitting to standing, he may feel giddiness. Exercise intolerance, silent MI, and sudden cardiac death or cardiovascular autonomic neuropathy. Gastrointestinal autonomic neuropathy like esophageal dysmotility, gastroparesis, diabetic diarrhea, constipation, and fecal incontinence can occur. In urogenital, there can be neurogenic bladder, sexual dysfunction, erectile dysfunction, and female sexual dysfunction, and retrograde ejaculation, pseudomotor changes, that is peripheral anhidrosis, that is loss of sweat, and increased sweat or gustatory sweating. Like if a patient is complaining of increased, usually it will be there, but more than exaggerated sweating on after eating or while eating, think of diabetic, some autonomic neuropathy. It need not be diabetes. Next, this is a new concept. One is, this is the treatment-induced neuropathy of diabetes. Initially, it was called insulin neuritis. It is not only for insulin, but also for other OHAs. So, treatment-induced neuropathy of diabetes is an emerging concept, and this everyone should know. This also will present with a small fiber symptom. So, it's not like the diabetic patient only will present with small fiber symptoms because of small fiber neuropathy, because of as such diabetes. But even the iatrogenic, we can induce neuropathy in some patients. That is called treatment-induced neuropathy of diabetes. It's an iatrogenic small fiber neuropathy caused by abrupt improvement in glycemic control. Like when we do good for the patient, it can become harm for the same patient. In the setting of chronic hyperglycemia, if you reduce the sugar drastically, like see, the definition is acute onset of neuropathic pain under or autonomic dysfunction within 8 weeks of large improvement in the glycemic control specified as HbA1c of more than 2 points improvement over 3 months, and within 8 weeks of the duration, patient can present with neuropathic pain and autonomic dysfunction. Usually it is a length dependent and it can involve the whole body also. This is more common in, it's not like it's a type 1, type 2. Any patient can present like with this, type 1 or type 2. It's a pain and autonomic dysfunction, burning or shooting pain in length dependent, distal or diffuse proximal pattern, frequently accompanied by allodynia and hyperalgesia. The symptom treatment is a symptomatic treatment, and there is a controversy whether we should we should not decrease, whether either we should avoid decreasing the sugar drastically or not. It's a controversial one. But as of now, there is no guideline for you should not reduce the sugar drastically or like that. Second is the impaired glucose tolerance of neuropathy. That is peripheral, because not only the diabetes, the pre-diabetic stage can also present with a small fiber neuropathy with autonomic dysfunction. So any patient with painful peripheral neuropathy should undergo, if the patient's RBS is normal, don't leave there. Go for oral glucose tolerance test. There patient may have an impaired glucose tolerance, and even with the clinically definite diabetes mellitus, peripheral neuropathy can set in. Never forget. In any adult patients with the painful peripheral neuropathy, if sugars are normal, don't leave it. Just do an OGTT. Then comes a hyperglycemic neuropathy, where it's a transient phenomenon, transient pain and paresthesias in a duly detected diabetics, and symptoms usually resolve when hyperglycemia is brought under control. Then this is very important. Then the lumbosacral plexus. Up to this time we saw the symmetrical one. Now it's an asymmetrical one. Here sometimes the diabetic patients will present with pain over the anterior aspect of thigh. Never forget, because we usually miss it. We will think it of an meralgia paresthetica, or we will think of any other problem like some orthopedic problem or something, OAE, osteoarthritis. We will think of osteoarthritis. But when a patient, this is called diabetic amyotrophy, that is the muscles will get wasted. It is a Bruns-Garland syndrome. Lumbar is usually involved. Then comes the lumbosacral involvement, that is the plexus and the sacral. It will be severe unilateral pain in the anterior thigh, sometimes in the lower back or hip. It heralds the onset of neuropathy. Within weeks or days, they will develop the pain and they will develop weakness, mostly the proximal than the distal one. And usually the knee jerk and the ankle jerk will be absent. And another history is weight loss. Extreme weight loss will be there. Up to 5-6 kgs weight loss can be there. And then it progresses steadily. So it's a debilitating, painful, asymmetrical motor neuropathy with profound atrophy. Then the patient will, the muscle will go for atrophy and weakness. And usually pain will spontaneously regress before the motor strength begins to improve. Recovery may take up to 24 months, and mostly it overlap with DSPN, that is a normal diabetic neuropathy in 60% of people. The vascular pathogenesis is implicated because of the infarction of the proximal nerve trunk and lumbosacral plexus. A symptomatic treatment is needed, and usually steroids can be given in acute stage, but no definite studies are there. Then comes the truncal neuropathy. Never forget this. If you see this, so when some patient is telling you, I have a numbness or I have a burning pain here in the trunk of involves the T4 to T12 thing, and it is coming from back to front. And when you examine, there is no herpes zoster or anything. And if the patient is diabetic, think of diabetic truncal neuropathy, because there are no tests to prove this. These are all clinical things, and if you treat, patients will become better. So never forget. This anterior thigh, if you want to take 1 or 2 points from this class, take away this anterior thigh pain and the truncal neuropathy of diabetes. Pain and dysesthesia in the area of chest and abdomen, bulging of weakness of abdomen muscles can occur, and it may mimic an intra-abdominal, intra-thoracic or intraspinal disease or even herpes zoster, but nothing will be there. Patient will tell of pain, you take every investigation, everything will be normal. There comes your clinical thing and the things you know. So never forget this. Coming to limb neuropathies. The limb neuropathies can be of two things. One is nerve infarction, and second is the entrapment neuropathy. In nerve infarction is less common. Cranial neuropathy, in the infarction pathology, cranial nerves are more involved than the limb neuropathy. Abrupt onset of pain followed by weakness and atrophy is common. Mainly the median, ulnar, and your common peroneal nerves are involved. and the entrapment neuropathy. These people are more go for entrapment because of single or multiple nerves can be entrapped. 8 to 12% with carpal tunnel have diabetes. So the same, it can present as carpal tunnel, claw hand, or a foot drop. Then comes the mononeuritis multiplex. Either these more than or equal to two nerves in non-contiguous manner. It should not be in the contiguous, non-contiguous manner. Either serially or simultaneously can be affected. Involves proximal muscles, as we saw the diabetic lumbosacral plexopathy. This is because of nerve infarction from the occlusion of vasovasorum. It is your systemic vasculitis. Then comes your cranial vasculopathy. This is oculomotor nerve is most common, where you can see the right-sided ptosis in an elderly patient. And if you see this patient coming with this, look for the pupils. If the pupil is spare, think of diabetic neuropathy. Usually because infarction, this pupilomotor fibers are in the outside, and your the central oculomotor axon is the center. If there is a vasculitis, that is vasculopathy, vasovasorum infarction, your pupil fibers will be spared. But if there is your any aneurysm is compressing your pupils, since the pupil fibers are externally thin, if and they will have a pupil involvement. So peripherally located pupilomotor fibers are spared. This is the reason. And third is the most common, followed by the fourth nerve, sixth nerve, and then seventh nerve. And caution, in a patient, in a diabetic patient with cranial nerve palsy, there are two things you have to look. First is the pupil. If pupil is involved, rule out compression of the nerve from outside like aneurysm. Second, look for other cranial nerve. If multiple cranial nerves are involved in a diabetic patient, be careful, don't be happy. Rule out base of skull osteomyelitis, especially by Pseudomonas, causing malignant otitis externa, and fungal causes like mucormycosis. Never forget. Look for eschar in a patient. As this mucor, there will be eschar over the patient may present with DKA. Patient may have an eschar over nose or somewhere, and then patient will go for rapidly. The patient will deteriorate and die within 2-3 days. Never forget, in a diabetic patient, cranial nerve palsy, you look for pupil, look for multiple cranial nerve involvement. Then comes the diabetic CIDP, that is chronic inflammatory demyelinating polyneuropathy. It is usually associated with diabetes, 9 times higher than in general population. It's a and this is like the patient will present with a predominant motor symptom, like proximal more than distal motor symptom, with distal sensory loss, with the loss of proximal reflexes. Think of CIDP. It will progress over 2 months. Electrodynamically demyelinating pattern will be there. CSF may show increased protein. Then comes diabetic neuropathic cachexia. Here, the patient will have severe weight loss, depression, insomnia, impotence will be there. Men are more affected than females. You can see the severe wasting of the person. Usually, the treatment is insulin. Control the diabetes, they will improve. You can see severe wasting of muscles of upper and the lower limb in a patient presenting with the diabetic cachexic neuropathy. Last is the acrodystrophic neuropathy, where sensory loss is there because of the large fiber involvement, makes the diabetic susceptible to repetitive unnoticed injuries that set the stage for foot ulcer and distal joint destruction. There will be chronic foot ulceration will be there. And this is very important, Charcot joint. Because this is because the patient will go with the swelling of joint to many doctors, many orthopedicians, and many everywhere, but it is not much treatable. Okay, and you have to pick it up early. You cannot just go on doing investigation and ask the patient to wait. So it's a complication seen in diabetics who have often foot ulcers and autonomic involvement. A condition, it affects the bone, joint, soft tissue of the foot and ankle. The main thing is they will have an unperceived repetitive trauma. You can see here there is a swollen the limb, lower limb bilaterally, and this here the left lower limb is affected and the right. You can compare it. And that it is a markedly swollen, warm, often erythematous foot with only mild or modest pain or discomfort. They will have a swelling with inflammation, but they will not have pain. This clinical picture will resemble cellulitis, DVT, or acute gout. They can present, everyone will test for uric acid, they will go for venous Doppler, arterial Doppler, but initial stage, pulses will be palpable and pulses will be bounding actually. Very good thing will be there. Later only they will have an ischemia. So they will have a classic rocker bottom foot. That is, this is the arch. This middle zone will get compressed so that they will have a rocker bottom foot with a chronic ulceration. When you see this, Charcot joint is usually a complication of any peripheral neuropathy. Like there are hereditary condition causing this, but since diabetes topic, diabetes is the most common for this. Then there is something called diabetic pseudotypes. Patient with severe lancinating pain, loss of joint position sense, diabetic pupillary abnormalities, bladder dystonia, neuropathic joint, that is tabes dorsalis. Like it will mimic like a syphilis. Pupillary abnormalities include constricted pupil with sluggish light reaction. It's a pseudo-Argyll Robertson pupil, approximately around 20% of people. And last few 1 or 2 slides, there are few genetic conditions associated with diabetes. Especially if you see these patients, you have to look for constantly. You have to go for screening of diabetes. That is, one is Down syndrome, Klinefelter's, Turner's, Wolfram syndrome. That is diabetes insipidus, diabetes mellitus, optic atrophy, deafness, Didmot syndrome, Friedreich's ataxia, and Lawrence-Moon-Beadle, myotonic dystrophy, porphyrias in Prader-Willi. In all these things, if your patient is having this thing, go for test frequently. You have to look for sugars and the cardiac involvement. In some there are cardiac involvement. And finally, the neurological abnormalities in infant of mothers born to diabetic mothers. Mainly congenital abnormalities like neural tube defects, anencephaly, encephalocele, spina bifida are common. Cognitive impairment, deficits in intelligence, memory, and verbal tasks are seen. Motor disorders like delayed motor development, poor gross and fine motor control. Psychosocial disorders like autism spectrum disorder, ADHD, and schizophrenia are reportedly common in the infants of diabetic mothers. So this is in nutshell like how to treat it. It is the multi-disciplinary action. First is treat the diabetes, then treat the cardiovascular risk factors. Then comes your painful diabetic peripheral neuropathy, and then you have to prevent the complications of diabetes like food care and other things. So in a confirmed diabetic peripheral neuropathy, first give, and you can start anything. Anticonvulsants is the carbamazepine or oxcarbazepine, but what we prefer is your the gabapentinoids, like is gabapentin and pregabalin, and then we will combine it with the tricyclic antidepressants like amitriptyline and nortriptyline, and the SNRIs like duloxetine, venlafaxine, mainly duloxetine, and anticonvulsants like carbamazepine, oxcarbazepine are used. So it's like a combination, and mainly avoid opioid analgesics. So this is in a nutshell. So that's all. Thank you. Thank you.
Thank you so much, sir, for enlightening us with such an informative presentation. We have learned so many neuropathic conditions which correlates the field of diabetology and neurology. And we extend our heartfelt gratitude for your participation, sir. And I would like to thank the Medicine Forum for arranging such educative sessions and making the students to understand the concepts here. Thank you all.
Thank you, sir. Thank you so much. It was really a wonderful session covering all the parts of neurology and correlation with diabetes. And we wish that we will have many more sessions from you in different occasions. Sir. Thank you once again, sir.
Any questions?
No, sir. Actually, we have a feedback form in which we will be receiving questions. So once we receive the questions, we will forward to you, sir. So once if you're free, you can just go through and just give me the reply so that I'll be posting in the group, sir.
Yeah, sure. Thank you. Thank you for giving me.
Yes. Over now.